Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am one of your co hosts, Jocelyn Turner. Our other one says he's having some technical difficulties, but I don't know, Dr. Panaya and Tyrone. I think because it's a beautiful day and he's out on a fishing boat somewhere. What's your guess?
That could be.
He may be on a boat, but he ain't doing no fishing.
You don't see that? You don't see Dr. Kane out fishing, Tyrone?
No, I do not see him out fishing.
Well, we are super pleased to have Dr. Sandeep Panaya, a local gastroenterologist. Dr. Panaya, I like saying that to make sure that I'm pronouncing it correctly. Did I do okay?
You were doing excellent. You guys got it. Thank you for having me.
Oh, absolutely. I'm going to first ask you, I'm going to start with asking you to tell our audience as well as me a little bit about you, as I did not remember to plug in my laptop and I don't want it to die on us in the middle of a conversation. So if you would do me a favor and go ahead and start and just tell our audience a little bit about yourself.
Absolutely. So as you mentioned, my name is Sandeep Panaya. One of the gastroenterologists over at Borland Groover here in Jacksonville. I practice out of the Riverside location. I've been with the group for about 2 years. I previously practiced in Gainesville at the University of Florida. But I'm just happy to be here. I'm happy to talk about colon cancer, obviously. It's Colon Cancer Awareness Month. Just excited to share, very real and very important issue currently for us.
Wonderful. And I'm going to I can't help but saying it. And Dr. Kane's not going to like this, Dr. Panaya, but go Gators. I just have to say it.
Absolutely. Go Gators.
Welcome, Dr. Kane. I gave Dr. Panaya an opportunity to tell our audience a little bit about himself. And Dr. Kane, I have to admit, I told our listening audience that you were probably out on a boat somewhere fishing, but Tyrone didn't go for it. He said you might have been on a boat, but you weren't fishing. So was he right or was I right?
Neither one of you.
I told her the closest you get to fishing is pointing to the fish at Publix.
and even then, it's more of a beef thing, Anyway. Welcome everybody.
So far, so good. A beautiful day.
Dr. Benai,
beautiful day.
Good speaking to you. I'm happy you was able to join us. I was having a little problem signing in. I can't tell you what was going on. Tyrone will tell me after this is over and done with. He'll fix me up. So,
well, we're ready to get started. And as Dr. Panaya says, it is Colorectal Cancer Awareness Month. Dr. Panaya, when I mentioned to some folks that we were talking about this tonight, they asked me, "Why are you talking about that? Is colon cancer a real big problem?"
Yeah, no, I'm glad you asked. It actually, it is becoming a bigger issue, I think, than it was. It's currently the third most common cancer, and interestingly, the second leading cause of cancer-related death. I think it's making a lot of waves now because we're seeing a lot of young patients and a lot of young people, especially under the age of 50 and younger under the age of 40 and even in the 30s, where we're seeing a lot more colon cancer. And these rates have actually doubled since the 1990s. So we've actually made, as a specialty, changed some of our guidelines where we used to start screening at age 50, and I guess we'll talk about this soon, but now we're screening earlier at age 45. So this is definitely an important issue, and it's one of these few cancers where early detection can really save your life.
So when you talk about, changing your guidelines and lowering the age, do you have to be at risk? Like, did you have to have a family member who had colon cancer, or how do you determine that? Who gets it earlier?
Yeah, good question. So for average risk patients, so those are patients that have no, family risk, no family history, no underlying genetic issues. Those patients should start getting screened at age 45. If you've got a family member, a first degree family member, what that means is mom, dad, brothers or sisters, you want to, get evaluated or get screened at age 40, and sometimes earlier, depending on when those family members, got their colon cancer. So that's sort of how we sort of risk stratify and start screening patients.
So, Dr. Benign, what makes why do you think that we're seeing more colon cancer these days than previous, and what necessitated us to start screening it earlier, especially in lieu of the fact that we have been screening for colon cancer for some time, and now all of a sudden we've seen this. It appears that we're seeing it in lower ages. Was that a matter of? Is this something we think is environmental? Is it because we're doing better, making greater efforts at our screening, and so on and so on? What would be the reason that, if you had to postulate, why would you think that we are seeing more colon cancer these days?
Yeah, and that's a good question. This is a really hot topic now, actually actively being studied. I think there are some risk factors that have been identified. Some of these are sort of lifestyle related things, obesity being one, inactivity, poor diet, smoking, heavy alcohol consumption. And then other things are, things that we really can't control, like, family history and, genetic syndromes. But pertaining to your question, I think the reason why we're seeing, and I think the current theory being why we're seeing so much more, young folks being diagnosed with colon cancer, is probably just the changes in environment and lifestyle and kind of our Western diet. So processed foods are sort of the big ones. Your chips, your cookies, your hot dogs, preserved meats, pizza, all the stuff that's great, right? All the stuff that we love to eat. Interestingly, they've identified that sugar sweetened beverages, and the sweet spot seems to be about more than two sugar sweetened beverages a day.
Wow.
Can contribute. Yeah. And I mentioned obesity and activity. And they really, the theory right now is, all of these things sort of change your gut microbiome, right? And so that's that. The millions of bacteria that we have in our intestines, how this diet sort of changes that environment and promotes inflammation and cancer. So I think that's sort of where we're sort of focusing on now, but again, actively being studied. And I'm sure as the years go by here, the months go by, I'm sure we'll have more answers.
And when Chadwick Boseman, I think that's what he died of, colon cancer. It seemed to be popular, if you will, at that time. And I don't know if there was an influx of folks going in for screening at that time, but unfortunately, that's when a lot of people start really paying attention to it, when a celebrity
absolutely
is diagnosed and it's publicized.
I can't tell you from what I saw. That's when I from my observations, that's when I began to see the lowering of age, more publications about screening earlier, especially once, like you said, once the celebrity got diagnosed with it at such a young age. That was a telltale story as far as what we should probably be screening at an early age. Even though I think a greater telltale story would have been with, who's the two baseball players that both wound up, they were childhood friends, and they both wound up with colon cancer, Dr. K and Darryl Strawberry.
Yeah, Darryl Strawberry for sure. I'm forgetting the other one. Yes.
Dr. K was the pitcher, that I
Hmm.
think his first name might have been Dwight, but he was just an awesome picture, and they both was in the major league at the same time. They were childhood friends, and both of them wound up getting colon cancer within a year or so of the other.
And they both died from it?
No,
Oh, okay.
They just
Oh,
was
okay.
diagnosed
Both diagnosed.
which was significant. And I think one was like 39. Both were, I think one was 39, the other might have been 40 or something.
Yes, they were. I think it was Dwight Gooden, if I remember correctly. They were.
Good. Yeah. Dr. King. Dwight Gooden. That's him.
Wow, wow. So what symptoms should people watch out for, especially young adults?
Yeah, that's a good one. So generally, when I talk to patients, when I see them in the office, I hone in on 4, maybe 5 symptoms. I think the first one is the obvious one, which is rectal bleeding. Rectal bleeding, any sort of changes in your bowels, any sort of new change. So any new constipation, any new diarrhea, that is sort of, out of the ordinary. If you get labs with your primary doctor or with your family doctor and you start, getting anemia, that word gets thrown around quite a bit, and you don't have a great reason for it, then of course, that needs to be evaluated further. I think the fourth one would be abdominal pain, which, can occur with a myriad of conditions, but if you have pain that you can't really explain, you should probably get referred to a gastroenterologist to get further evaluation. And then I'd throw in weight loss as well. If you have sort of unexplained weight loss, you're not intentionally trying to lose weight, you're not on one of these new weight loss medications, you should probably get investigated further. Now, I just want to go back and touch on rectal bleeding. I think historically, if you had a young patient that said, I'm having rectal bleeding, I think, the inclination was to say, maybe you have hemorrhoids or, it's probably hemorrhoids. Let's just watch it. I think there's been a shift now where, if we hear that, we are less likely to take chances, and we've sort of maintained a lower threshold to say, okay, let's maybe do a procedure and take a look. So I would hone in on those 4 or 5 things there.
Yeah, back in my day when we were doing residence as a resident, of course, you guys were still in diapers. Back in my day when we were looking at that, just because the hard and fast rule to especially interns, externs, interns, and then first year residency was that just because they have hemorrhoids doesn't mean that rectal bleeding is coming from the hemorrhoid. You need to investigate as to other potential causes, especially colorectal cancer, as being etiology of the bleeding.
I remember when I was Dr. Panaya, I'm a health educator, public health educator. That's where I spent most of my career at the health department. And I used to have conversations with people about this and checking your stool, and we haven't talked about it, and it's not a pretty question I'm going to ask, so I'm apologize in advance. So as people are looking at their stools, should they pay attention to the shape of it? And when you talk about noticing differences in your stool, I mean, does shape and size and all of that have anything to do with the changes that you might notice?
Yeah, absolutely. That's actually a great question. I'm glad you touched on that. So any sort of change in the caliber of your stools, especially if your stools are, the classic teaching is pencil thin or, just thin, you want to think about maybe there being some sort of obstructive process or something maybe causing a blockage that might be changing, the way your stool's coming out. So absolutely, I think that's really important, and not just thin stools. If your stools have gone from solid to being liquid, if you're noticing blood within the stool, not necessarily just on the toilet paper, all of these things. So yes, as you mentioned, it's not maybe the first order thing you're doing when you're going to the bathroom, but I think getting used to that, especially now with the rise and incidence of colon rectal cancer, I think it's helpful.
Is there any, and Dr. Kane, I don't know, and you feel free to chime in also. I'm not just going to keep putting Dr. Panay on the spot, but is there any food that might make you think that there's blood in your stool, but it's really the thing that you consumed, so that people won't panic if they see something?
The easiest one that come to me is tomatoes, because sometimes tomatoes go in and come out looking the same.
Mm.
Anything that is of red content,
Yeah.
that could have come out on the other end. And one of the things that people don't look for is dark stools, because remember, if blood is processed over an extended period of time, it comes out more blackened than fire red.
Yeah, absolutely. And as you alluded to, Dr. Kane, tomatoes. I think beets is another one too. A
Yep.
lot of people will do beet salads, that kind of thing. There's also people that just have kind of underlying gastrointestinal issues, and they'll take a lot of Pepto. Pepto
Yep.
can change the color of your stool. It can make it dark. If you are on iron supplementation, that can change the color of your stool. But I think it's best to just sort of, if there's any change, address it, right? You address it with your primary doctor, your primary provider. If you're plugged into a gastroenterologist already, bring that up. It's just best to kind of, mention that and say, hey, I don't know what you think, but this is what I'm noticing, rather than, putting it off or saying it's probably nothing.
And we always
and to reflect back on one thing that you did say when you started discussing the content or the appearance of stools. That's the other thing. I mean, I know we talked about pencil thin stools, but a lot of times, I get suspicious if all of a sudden you start getting constipated. Not so much that I know you probably did mention constipation, but a lot of times it can be constipation or diarrhea. So on either end of the spectrum, people have these, hey, look, I'm having these droplets, balls, or whatever in terms of my stool, where I didn't have that before. And that needs to be brought to the attention of your primary care or your provider, for sure, primary care provider. And of course, when people like Dr. Panay see him, they're going to ask those more poignant questions. But at least in terms of awareness, just any change in stool habits, that especially if they're all of a sudden a change in stool habits.
Absolutely.
If you're just tuning in, joining us tonight is Dr. Sandeep Panaya with Boyle and Groover, and we're talking about colorectal cancer. I know people who've unfortunately had loved ones who've been diagnosed with colon cancer. So make sure you tune in, chime in, ask Dr. Panaya a question. This is your opportunity. Share the video so that others will tune in and listen and learn, because that's what it's really all about. So, Dr. Panaya, I must admit, I hate the dreaded gold standard of screening, as we all do, the colonoscopy. Before we get into it, and you can talk about it as you or answer this question as you talk about it. I was listening to Family Feud. I'm a Steve Harvey Family Feud fan. And there was a contestant on there who, I don't know if she was a gastroenterologist or just a GI nurse, but Steve mentioned that they told him not to come back for 10 years. And she had mentioned 3 to 5. He was like, 3 to 5? Wait a minute, they trying to kill me? How come they told me to come back in 10 years? So why does it, let's talk about the colonoscopy, the one that you do for your patients, or the ones that, those mail-in ones, who should do that? And then also talk about, how do you determine how soon a person should come back for a colonoscopy? I know it's a loaded question, sorry.
No, I think there's a lot to unpack there. I think it's all very important. So when we think about screening, we really think about, as of now anyways, two screening approaches. I'll start with kind of stool-based testing, right? And there's various brand names. There's Cologuard, there's FIT. There's different stool-based tests, and essentially, what these do is they detect the blood and DNA in the stool. The benefit is that it's not invasive. The drawback is that it's not preventative, meaning you cannot take out polyps with a stool test, right? It's just going to be positive or negative. The other drawback is that a positive test means that you need a colonoscopy. So any positive test means you're still going to need a colonoscopy. And I think the biggest limitation with the stool-based test is it's not really a great test if you have a family history of colon or rectal cancer, and it's not a great test if you have a history of polyps. So, so as long as you understand the limitations, a stool-based test is okay. I think the most comprehensive or the main test that, you know, most of us or all of us as gastroenterologists are going to recommend is a colonoscopy. And that's where not only do we get to diagnose these, but it's preventative. We take them out. So we're essentially, you know, taking away your risk of developing, you know, the colon cancer. Now there is a third, which is kind of on the come up, which is a blood-based test, which is not widely available just yet everywhere, but this is a little bit less accurate, and it's still not our gold standard. So that's kind of how, you know, I would think about screening. Ultimately, the best test is the one you actually do. So, if right. So as long as you get one done, I think you know, you're doing yourself some good. But you know, if it was my family member, my spouse, I would still recommend the colonoscopy as a preferred
You know,
approach.
last time I got my colonoscopy, there was a woman, I heard her, she was so upset because she didn't drink all the yucky stuff. And so the doctor couldn't perform the procedure. And so she had to come back. Talk a little bit about the importance of following the doctor's advice about the prep.
Yeah, absolutely. So, and I realize I didn't maybe answer the last part of your, the last question, which is, you know, how often you recommend doing these? And it really just depends on what we find. Generally, if we don't find anything and we get a really good look, as you mentioned, 10 years is, you know, when we do the next one. Now, when we think about doing the colonoscopy, I tend to sort of break it down in three whenever I talk to patients. I think first is the prep, and that is the part of the procedure that we all hate, right? And that's, you know, to be brutally honest, that's just not the fun part. So it's a liquid diet one day before the procedure, and then you drink, you know, this stuff that, you know, some people hate. The good news is there's, you know, different volumes of this. There is a low volume option that's just 1 liter. We even have a tablet option now. We have a 2 liter option, and then of course the 4 liter one, which I'm sure, you know, everyone, if you've done a few of these, has done once in their life. We do recommend splitting the prep, so you drink half at a portion of time, the other half, at you know, some hours later, or half the evening before, half in the morning. So that's the prep. The procedure in itself is honestly the easy part if you can get through the prep. That's where you come into the endoscopy center, you get an IV. At least with Borland Groover, you get sedated by an anesthesia provider, so you're completely out. You shouldn't, you know, feel anything, hear anything. You'll be deeply sedated, and 20-30 minutes and you're usually done. So that's a procedure. And then the recovery piece is where you go to the recovery area. You're there for anywhere from 30 minutes to an hour. And then you're usually probably thinking about where to eat. And you probably already have a restaurant.
I remember back in the day when I was an extern, the very first colon exam we did was a straight tube, you know, that you insufflated, with, you know, insufflated and tested with air. And if as you're Dr. Panay, you will certainly know, but some of our audience may not know. You know, when you go into the rectum, you take a little bit of a turn to the right, and then you start going more upwards. You know, and that straight tube did not turn, and
Right.
it was one of the most uncomfortable things, not just for the patient, but for me too, because they was moaning and groaning so bad, you know. And so when you guys start using sedation and everything to assist with that made it great. But my brother had one. I think one of the best lines I ever seen when he had his colonoscopy done. and he came out and he was talking to the doctor, and it was Dr. Rawls, and he said, "Can I have one of those to go? Because the sedative that they use is some of the best sleep you're gonna ever have."
Absolutely.
I call it the Michael Jackson drug, but you know.
Yeah, no, absolutely. We get that a lot. We get a lot of people that'll say after, "Can I do that again?" Or "Can you give me some of that stuff again?" For sure, for sure. And I just wanted to point out, we might have glossed over maybe the most important thing is, when we say colon, when we say rectum, we should probably define that when we say polyp, because I get a lot of questions in the office when people ask me, "What is a polyp? What are y'all talking about?" And so, the colon is the last part of your intestine. It's your large intestine. We use colorectal or we use colon, but it can mean colon or it can mean rectum. The rectum's just the very last 6 inches of the colon. So the colon's about 5 feet. The rectum's the last 6 inches. Polyps are little growths that grow within the skin of the colon or the rectum. And then over time, these polyps can develop mutations, and that's how cancer develops. But I think the point of emphasis is these things develop slowly, over 10 years, over 15 years, which is really the basis for why we screen, which is why, we want you to get this done at 45 and then again in your 50s, because there's this window of opportunity, right? So when we see these polyps, when we see these growths, we take them out before they develop mutations, before they, grow larger. So that's just a little bit to kind of define, the colon, the rectum, and the intestine and polyps. So just wanted to add.
The most simplistic thing that I put the patient, it might be overly simplistic, but when they ask me what a polyp is, I say, well, if you look at your skin, you see a mole,
right.
And you can see the mole, and a lot of times we can tell whether or not it's cancerous or not. I say, so imagine if you had a mole in your colon, we can't see it unless we go in there and look at it. And so it kind of can be equivalent to searching for skin cancer in terms of visualization, but it's in the colon, so that means we got to do a colonoscopy to actually be able to see it.
Right. And Ms. Turner, I think you were asking some tips. You'll get this information when you go in and see the nurse or the GI provider. But there's various things you can do. You can refrigerate the prep. You can drink it with a straw. You can drink it slowly and split it up. You can flavor it. Now some of our newer preps have flavored options. So there's various things, and based on your habits, based on your bowel habits, based on, if you're constipated, if you're not, they will, most GIs are going to come up with a strategy that works best for you.
And my strategy was do it right based on the instructions so that the GI doc can get it done and I can go and eat me a Whopper afterwards. Yes, I said Whopper.
And you don't have to do it again.
If you're just tuning in, we are talking about colorectal cancer. We're about to have our mid-show moment where Tyrone he's our behind-the-scenes guy, but he loves to do his research and surprise us each week. So, Dr. Panaya, don't go anywhere. Take a drink of water. We'll be right back. Take it away, Tyrone.
Welcome to Pause for the Truth. Mid-show minute. Today is March 21st, 2026. Real talk time. There's a dangerous myth I grew up hearing. What you don't know can't hurt you. With colorectal cancer, silence absolutely hurts. Here's the truth. CRC just became the leading cause of cancer deaths under 50 in the US. 1 in 5 new cases hits people younger than 55. Black Americans are 20% more likely to be diagnosed. Black Americans are 40% more likely to die from CRC. Myth versus fact. Myth. I'd know if something was wrong. Fact. Early CRC often has 0 symptoms. Early detection leads to 90% plus survival. Myth. A colonoscopy means a hospital stay. Fact. It's an outpatient procedure. You go home the same day. Myth. Docs will bring it up if I need it. Fact. Many people say it never gets mentioned. Be your own advocate. If you're 45 plus, ask. If you have family history, ask. Today, good news. 2026 changed the game. AI-assisted colonoscopies act like a second set of eyes, boosting polyp detection by about 13%, possibly cutting future cancers by nearly 40%. Big caveat, some trials show the gains are mostly in smaller polyps. Still, extra eyes help. Hate appointments? There's now an FDA-approved blood test for average-risk adults 45 plus, a legit primary screening option. Blood-based tests. ours 90% sensitivity, blood-based tests, ours yadr 89% specificity, strong at earlier stages. Stool-based at-home kits are better than ever. Access matters too. Health systems using AI to cut call times and confirm appointments. Nearly a third of eligible adults aren't getting screened. Asian Americans have only a 50% screening rate. Bottom line, the best test is the one you'll actually do. Colonoscopy removes polyps on the spot. Blood or stool tests can be your first step. Don't wait. Text your doctor, schedule the screen. Tell a friend, you're not doing this just for you. You're doing it for the people who need you here.
Excellent. JT, you muted. JT, you muted.
So I was talking to myself, sorry. As I said, Tyrone always does a great job getting some good information and pretty much said what you were saying, Dr. Panaya. But can you speak to one of the things he mentioned in the video, but can you talk about how colon cancer specifically impacts the Black community? We mentioned Chadwick Boseman and the two baseball players, but why are we seeing that in the Black community?
Yeah, that's an important issue that I want to actually touch on today. So there's definitely a higher incidence and higher mortality, meaning death, in African Americans compared to Caucasians. And specifically when it comes to mortality, we notice that we find colorectal cancer at later stages in African American patients as well. Now, a lot of this is just driven by access issues, what we refer to as the social determinants of health, which I'm sure you all are very familiar with. Not necessarily the patient's biology, interestingly. So, historically, African Americans had lower screening rates, had sort of delayed follow-up, less access to treatment, and as I mentioned earlier, a later stage of diagnosis. But what's interesting is that when access is equal, these disparities actually completely disappear. And they did a large study in Northern California, actually at Kaiser, where they had this really organized system-wide screening program where they had equal access to for everyone. And they noticed that the gaps in screening rates, in incidence, and in mortality between Black and white patients actually was essentially eliminated over 20 years. So, the issue is really access, not biology. And so, I think there's a few things we can do about this. I think number one, as we've been talking about, screening and knowing your age of screening is super important. Know your family history, and advocate for yourself. Talk to your family, figure out who's got a history of polyps. Someone's getting a colonoscopy more frequently than you think is normal. Note that and address that with your primary doc or with your GI physician. And if you have any of the symptoms we mentioned earlier, definitely be aware and bring that up.
Ms. Turner, historically, and Dr. Panay, you may have been, well, no, I'm eons ahead of you in terms of education, but not how smart I am, just the age. Yeah, eons ahead of you. But I remember back when we first started looking at this matter intensively, back in my day, we talked about the Bantu tribe in Africa, in which that was one of the tribes that had a lower rate of colon cancer. But then I found out later, actually, that was not a tribe, but a group of people that spoke a particular language. And even though it was in Africa, they tend to have worldwide, they have much lower rate of colon cancer than, at least initially when we were looking at it, much lower rate of colon cancer. It's funny, not funny in terms of hilarious, but it's funny how times have changed in that even now, because of the westernization of diet, you're now beginning to see those same African Bantu-speaking populations start their rate of colon cancer start equivalating to what we're seeing in the Western world. And I think that's because of the penetration of the Western diet.
Absolutely.
And you said that there is no difference in terms of gender, Dr. Panaya?
Yeah, there are some slight, amongst race, there are some slight differences in terms of, where you notice cancer or left or right sided. But that, you really have to get into the weeds there. But overall, I think when we talked about kind of the incidence of mortality in blacks versus whites, it was what I mentioned earlier, and that's not gender specific.
Why do you think, and Dr. Kane, I want to ask you this because I was talking to one of your patients earlier today. I'm not going to reveal who they are, but why do you think when you make a referral for the colonoscopy, folks don't always follow through with it? Is it the prep, you think, or is it the fear of what they may find?
Well, I think it's some of both. I think the larger of the two is the prep and what they've heard about the prep. Not so much that they've even experienced the prep. Okay. If they have experienced it and then they come back and say, I really hated that, I can deal with that better. But as opposed to the ones who never had a colonoscopy done at all, listening to their friends and family members, whom, if you're a friend and you're a family member and you really want to and really love that individual, you would not be, I repeat, you would not be criticizing getting a colonoscopy or not be, demeaning getting a colonoscopy, as we've heard sometimes in the population that we speak. But yeah, that basically, I hear more about the fear from what family members say it's all about, more so than the patient actually has experienced it. Because many of them that have experienced it, other than the prep, as they would tell you up front, and now because of, like what Dr. Panay says, because of the different mechanisms by which we use prep, unlike when I was taking it, you had to drink a liter of Gatorade and whatever else it was, and trying to get the whole liter down was tough. The different ways to get them prepared right now, so there's really no excuse in terms of getting that preparation. Is that I think the fear that's been installed by some of the family members who experienced the old-fashioned way of drinking 2 liters of Gatorade trying to get prepped.
So a lot of people avoid this topic, again, even when I was mentioning it to people, because it seems to be uncomfortable. How do we normalize this conversation about colorectal cancer and the importance of screening? And that's for either of you.
Yeah, I mean, I think, going back to, I think, what you were saying, Dr. Kane, or maybe Jocelyn, when you were talking about why people don't, always, a third of the population that needs screening hasn't been screened, and so why are these patients not pursuing this? I think historically, I think before you heard about celebrities getting colorectal cancer, I think in terms of fear, it was always, and anecdotally speaking, it was, your heart, your pancreas, you hear those things and it's like, okay, I've got to get this addressed ASAP, right? And it's, okay, well, mammogram, okay, we'll do that when we need to. Bone density scan, we'll do that when we need to. Colonoscopy, we'll do it when we need to. But I think now is sort of, we have, celebrities getting this, people that are getting this much younger. I think, it's sad to say, but that scare factor, I think, is becoming a little bit more prominent, and I think people are taking this a little bit more seriously. Of course, we have a lot more awareness now. We're of course doing this podcast. There's this kind of thing that's done more routinely, which I think is driving the message home. But yeah, in terms of normalizing it, I think it starts with the facts, and I think it starts with understanding what the procedure entails, and I think then it becomes a lot less scary.
And I also have to dismiss sometimes the what's the word I'm looking for? The fallacy that because I don't hurt, I don't feel anything, it doesn't hurt, so why do I need to get it done? If I'm not hurting. But that's the same thing we say about high blood pressure just before the stroke shows up.
Right, and just to kind of throw some numbers out there, and the reason why we really focus on early detection. When we detect a colorectal cancer early, so early stage, your survival is upwards of 90%. When we detect a colorectal cancer late stage, or when they're spread to other organs, we're looking at survival dropping down to less than 15%. So that's, that goes to your point. Yeah, in its early stages, you may have zero symptoms. You are likely to have no symptoms. And so that is why, doing this and getting screened is important, because we're in there and we're looking, and you may not know that you're growing something that is about to be cancerous or is cancerous.
So if someone doesn't have, they're really interested in getting a colonoscopy, but they don't have a primary care doctor, is there a way that they could, do you know of any resources that will help folks get that colonoscopy? And do you have to have a referral from a primary care physician in order to get the colonoscopy?
Dr. Rogers or Dr. Kane, I don't know if you're best.
Okay.
best
Yeah, I can answer that.
know the ins and outs with insurance, to be honest with you,
Right.
and payment.
Yeah, of course, without getting into the weeds of PPO and HMO and all that other stuff, a lot of people are getting referrals simply because when the provider, the gastroenterology, gastroenterologist and institution, when they look to get the colonoscopy done, obviously they got to get paid, because you can't stay in business if you don't get paid. And so they are trying to ensure that they do get paid, whether the person needs the referral or not. They try to ensure that if a referral is needed, that is done. So they do request the patient many of the time to get a referral from their primary care physician, even if they don't need it because they got a PPO and they can go straight to the physician themselves. The other reason that we also use the primary care provider to help screen for it is just to do that, to help screen the need for it, because you may or may not need one. If you had one 2 years ago, I have some people going like, do I need to get another colonoscopy? No. What did your previous one say? And of course, I look back. The previous one was straight up clean, and it was recommended to do 10 years later. But they heard from a relative, and just to clear up some of the misperceptions that people have about colon cancer and colon cancer screening, that the primary care guy is doing what his job is, a gatekeeper, to determine who needs it, who does not need it, okay? Or if you don't know, you punt to somebody who do. And that Absolutely. Would be like Dr. Bernard and Dr. Rawls and the rest of the Boyle and Groover clan.
Absolutely.
And I know that the Federally Qualified Health Center is also another option, the FQHC, for people who don't have a medical home. But we always encourage someone, to get a medical home, learn what your options are. Don't wait, because the one thing that the doctors have said about cancer, period, is it can spread or metastasize. And so prevention, that was a wonderful statistic, what Dr. Panaya said, that 90-something% chance of survival, if you will. And that means going in for routine screening. And that is the gold standard. I learned that from Dr. Rawls, the gold standard of screening, the colonoscopy. But it is dreaded. But like you said, both of you said, it is the best sleep. I remember the first time I got a colonoscopy, I said, okay, so when I woke up, I said, so when are y'all going to get started? And they all laughed. They were like, we're done. I'm like, what? It felt like I had been asleep for hours, and it didn't take any time. So it is a very important screening. One thing I want to talk about a little bit, and Dr. Panaya, this is when we usually have our resident registered dietitian on with us, and she talks about our diet. You mentioned about, high fat diet, obesity, family history. What are some other things that I was cheating, and then when I put it in our little sidebar over here, I put too many things, but I'm gonna try to read what I said. The colorectal cancer risk factors: age and demographics, age 45 and older, higher risk in African-American individuals, males, slightly higher, family and genetic risk, family history of colorectal cancer, history of colon polyps, personal medical history, previous colorectal polyps. It's just, and lifestyle factors, diet high in red or processed meats, low intake of fiber, fruits and vegetables. I know Linda, the dietitian, always says that we should eat things that don't come with a label. You don't have to worry about reading labels on fruits and vegetables because they're the best things for us. But probably the thing that most people get the least of, because when it's been a long day and people are busy, they're grabbing and going, right? Whatever's handy. And sadly, it's not always the healthiest choice, especially when you mentioned earlier, Dr. Panaya, about the social determinants of health. If people don't have the income to buy fresh products, that's why we, in my line of work, we encourage folks to consider growing a garden. If you don't know how, stop by one of the local feed stores, or you can even probably go in a nursery and they can help you. They'll want to sell you some seeds, of course, but that's how you want to get started. And consider growing your own vegetables, and learn how to flavor them up so that they will taste good. Tyrone, do we have a question or a comment that someone posted? I know I was rambling on, but I wanted to mention that we'll talk about some resources in just a second, but I want to ask a quick question, Dr. Panaya. Is smoking a risk factor also, or does it just make the situation worse if you're diagnosed?
No, it's certainly an established risk factor, both smoking and alcohol, alcohol in excess. But smoking definitely can trigger some of the pathways on kind of a cellular level, which increases the risk of developing mutations. So and which then propagates the cascade into cancer. So from normal tissue to cancer. So yes, it is absolutely a risk factor, and so we always counsel patients on on not smoking, and if alcohol is a big lifestyle related thing, cutting back so that it's just maybe social use. But yes, that is definitely an established risk factor.
I'm glad you said social use, because a lot of what you mentioned is all about what people do socially. So we also have, in addition to the general public, we also have some physicians on. Is there anything that you say, gosh, if I can get in front of a group of doctors, I would tell them blank? Is there anything that you can think of that you want to say to them? And I don't want to minimize their expertise, but just in general, what advice could you give? That are there any new advances coming out that they should look for or hope for?
Yeah, I mean, I think it's stuff that we've already touched on. I think I think we as medical professionals have caught up to speed with the new guidelines with screening, moving from 50 to 45. That happened in 2021. I think everyone does a pretty good job with kind of getting their patients in there. I think just there's been some controversial studies regarding doing non-colonoscopy based testing. So doing not direct visualization, but either pursuing stool testing or potentially blood work for screening. I think the evidence tells us that those tests are still suboptimal to colonoscopy. Now, if you do pursue one of those, you're still, any positive result there is still going to, lead to colonoscopy. So I think knowing that is important. Of course, there is, certain patients and a certain patient population where, colonoscopy may not be an option, either due to, anesthesia risk or, as you mentioned earlier, access. And there, you can pursue one of these other options. I think those are probably the two biggest tests. I think the other thing, two biggest points, forgive me. I think the other thing also is sometimes if we're not GI providers, we might think early cancers that require surgery, but interestingly, our techniques with colonoscopy and removing polyps is getting so advanced now where even early cancers and cancers that have invaded into the wall of the colon, we can take out. You don't need surgery, where else some years ago you did. So I think that's important to know as well, that our techniques are just getting more and more advanced, that we're able to avoid surgery and still take care of these patients and still rid them of early cancer.
And when we talked about the process, the prep, but when we actually show up for the colonoscopy, can you walk us through that again? What exactly should people expect when they go in for a colonoscopy?
Yeah, so like I said, when you come in, so you've done the prep, you've come in, hopefully completed the prep in its entirety. you'll come into the endoscopy center. You'll get your IV. You'll get you'll meet with a nurse. They'll kind of go through your history again, make sure you're not on blood thinners, make sure you're on not taking any medications that might interfere with either the anesthesia or or the exam. Once all of that's done, you'll chat with our anesthesia provider, and then you'll chat with one of us. You get in, you get sedated. Most of us will play some light music to make the environment a little bit more or a little less daunting, just to keep everybody relaxed. And then it's pretty much done. It's not a very it's not as scary as people think. The rates of complication are less than 1 in 1,000. Those are major complications, or perforation, which is a tear in the colon. So less than 1 in 1,000. And then you go to recovery, and you're there for 30 minutes to maybe 60 minutes, and then you're home. So we're looking at maybe 2 hours, and you're done with this. So it's 1 day of pain, maybe 24 hours of some pain and some agony and nuisance, but it's maybe 10 years or several years of peace of mind.
And I always see the 1 day of pain. The only pain is not being able to eat that burger that Jocelyn talked about.
I was teasing about the burger. But Dr. Panay, before we end the show, I want to ask you, and it might just be random, but I just have to ask, what made you choose, when you decided to be a physician, what made you choose gastroenterology? Was it because of family history? Because it's all kind of jokes. I'm sure you've heard from your friends or whatever about what you do every day.
Yeah, no, it's interesting. So my path to gastroenterology was kind of long and convoluted, and I did different things. But interestingly, I was also trained in family medicine, just like Dr. Kane. And so I did that first, and then decided that I was looking for something that was sort of more of a mix of procedures and hospital medicine and the office. And I wanted to do things that was sort of like being in the operating room, but not quite, and so that's sort of how I led to this. I also had a family member that was a gastroenterologist that I got to shadow, and I think that sort of highlights the importance of mentorship. And so that's sort of how I came to this. I'm very glad I did. I'm very happy doing what I do.
Wonderful. So there is a question: do doctors usually do other things with the colonoscopy, like endoscopy and other gastro-related at the same time?
Yeah. So we can combine the colonoscopy with an upper endoscopy, and then we could be doing each procedure for a variety of reasons. Today's talk was just basically about screening and looking for polyps, but sometimes patients have abnormalities that they pick up on CT, and so we have to kind of go in and biopsy these areas. Sometimes we're doing it for people that are in the hospital that are bleeding. We need to stop a life-threatening bleed, and so there's a variety of reasons we do this. But I think, to answer your question, yes, when we do a colonoscopy, we can also do an upper endoscopy, and we actually, if we do have to do the upper, we'll often try to do it with the colonoscopy, so it's done at the same time, so you're not getting anesthesia more than you need.
That prompted a thought that Dr. Kane will generally say, so I'll go ahead and say it for him. Then that means that you need to come back and talk about those other GI-related issues that we didn't talk about today, because we focused on colorectal cancer, because it's Colorectal Cancer Awareness Month. So are there any final words or key takeaways for our listeners as we wrap up today's discussion, Dr. Panaya?
I hope I'm not, being too repetitive. I just want to mention, of course, this is preventable, this is detectable, this is treatable. Please get screened, either 45, 40 or earlier. If you have risk factors, know your risk, talk to your family, figure out who had polyps, figure out if there's any cancer. And then specifically to our African-American audience, the disparities that we see are real, but they're not your destiny. So be your advocate, encourage your family members, stay engaged, and engage in podcasts like this, just to spread awareness.
Thank you. Thank you so much. Dr. Kane, what are your final thoughts?
I don't think I could have put it in any more detail, in any greater detail than Dr. Panay did. And that basically is that colon cancer, one of those few cancers that are very, very preventable before, before it starts. And what we have to do is just be on the lookout for it. Okay. Remember the symptoms that we talked about earlier in the podcast. Be suspicious of anything that's abnormal from a GI standpoint. Not saying everything that's abnormal from a GI standpoint is colon cancer, but be very suspicious. Dark stools, different color stools, different lengths to the stool, different size of the stools, abdominal pain, and so on and so on. I think those are the main things that we need to look for. And while we do our screening starting at 45, I also encourage patients, let's think about it between the age of 35 and 40, just in case, you may fit one of those rarities like Dr. K and Daryl Strawberry and his crew, or, sometimes you don't know what your family history is, particularly in the Black community, because we don't know what the family history is. So if you don't know, let's assume that you may have a positive one. So let's be aggressive in terms of screening for colon cancer.
Thank you. And thank you, Dr. Panay, for joining us. Tonight's conversation was a reminder that colorectal cancer is not something we can afford to ignore or put off. We heard clearly that it is a disease that often develops silently, but the good news is it's also one of the most preventable and treatable cancers when caught early. Dr. Panay helped us understand the importance of knowing your risk, recognizing the signs, and most importantly, getting screened. We talked about fear, stigma, and the hesitation many people feel, but the truth is a simple screening could save your life. This is especially important in our community where we continue to see higher rates and later diagnoses. That means we have to be more intentional about having these conversations with our families, in our churches, in our barbershops, and among our friends. So tonight, don't let this just be another conversation you listen to. Let it be a call to action. If you're 45 or older or younger with risk factors, schedule your screening, talk to your doctor, and if you're healthy, stay that way by being proactive, because at the end of the day, taking care of your health isn't just about you, it's about your family, your legacy, and your future. Thank you for joining us, and remember, sometimes the truth may be hard to hear, but it can also save your life. Good evening.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.